Good morning, everyone, and welcome to our town hall today on October the 1st. Welcome to a new month. My name is Aaron Levo. I'm the Vice President of Communications and Public Affairs. Happy, as always, to play the role of moderator for the Q&A function the Q&A component of today's town hall. We have a number of guests with us. When it does, we'll get to that in a minute, but when it does come time for the Q&A, you can ask questions in a couple of ways. You can type them into the chat function, use the Q&A function, or preferably raise your hand in the participants list and we'll call on you and you can ask your questions live. We have a few that we'll ask anyways that came through between the last town hall and today, but we'll hope as we go through the presentation, you'll be thinking of lots of things. So to get us started, I will hand it off to our President and CEO, Rob MacIsaac, to give us an overview of the topics we'll be talking about today. Over to you, Rob.
So thanks very much, Aaron. As I'm sure everybody is aware, the COVID landscape continues to shift, and the past couple of weeks have been no exception. I think the change in the trajectory of the virus in our community really highlights the need to continue to work together, to be vigilant and maintain our infection control practices, things like screening of staff and visitors, the use of PPE, support for assessment and testing, and the continued evolution of how we're providing care for the virus, both in hospital and virtual care. I want to thank everyone who's working on our teams and partners that continue to build our COVID-19 preparedness and response plans. That includes the work with partners in Hamilton and of course across the broader region. While we're hopeful that these plans will not need to be activated to their fullest extent, certainly super important that we're prepared for the worst. Many of the working groups we put in place to plan for our response to COVID-19 have continued to work together. Given that some of the changes in numbers across the province, HHS's formal incident management structure will also be reconvening in the near future. The Government of Ontario has also been sharing their plan to support future waves of COVID-19. This has included recent announcements regarding expanding testing and lab capacity, provincial funding to help address surgery and procedure backlogs, and staffing of congregate care settings. We're also working with partners to support hospital capacity. Some of these efforts include a regional shared care model, which will help us to ensure that we can support the care needs of COVID positive patients who require acute care. And very significantly, the opening of an alternate health facility for the care of ALC patients to free up acute care space. Sharon Pearson is going to update us on that today. I know COVID has impacted children and youth across our region. Bruce Squires is going to highlight some advocacy work underway with partners across the province to improve wait times for kids and their families. Just before I turn things over, want to thank all of you. I know many of you this past month has meant more adjustments for your families as school has returned and many other family members are getting back to their workplaces. So just thank you for your commitment to our patients and your colleagues. It's very much appreciated. So with that, I'll turn it over to Dr. Dominic Mertz, who as usual is going to provide an infectious diseases update. Dominic, over to you.
Yeah, thanks, Rob. I will give a quick overview again about on the epidemiology of COVID-19 nationally, provincially, as well as regionally, and comment on the questions we get pretty much on a daily basis. When are we turning on testing for X or Y? So first, starting off with the national picture here, hasn't changed a lot in terms of Quebec being the province with the highest numbers, followed by Ontario. On the right-hand side, you see that we are currently at around 23.6 weekly cases per 100,000 population, very similar to Alberta and Manitoba. Roughly half or less than half than where Quebec is adjusted for their population at this point of time. RT at 1.18, which means that with the current trend, we will see an increase of 18% every 5 to 7 days moving forward, unless we can change that trend. Next slide, please. Now, the provincial view hasn't changed significantly in terms of trends either. So you can see that upward trend that I showed you previously. The gray bars here are the more recent days where cases can still be added because we have, as you know, A, a lag until people get tested, B, a lag from testing until the test result comes back. But it also looks like, and being carefully cautious, cautiously optimistic here, that the upwards trend seems to be slightly flattening, but we will see over the next days what exactly is happening. Also important to mention here that when you're looking at the case counts, we aren't as far away anymore from the number of cases that we had at the maximum back in April. But keep in mind that we are testing much more aggressively. So I would say 650 cases back in wave 1 are the same as 650 cases at this point of time. And also very important to notice in terms of hospital strain, the population currently mostly affected on the elderly and vulnerable, which was the patient population that was mostly affected in those tested back in April. It's still mostly the healthy and relatively young population, which should not immediately put the pressure on our healthcare system. Next slide. With all of this in mind, that significant increase at the provincial level in terms of cases, when I get asked about shouldn't we turn off pre-procedural tests, pre-procedural testing again, as an example, we are really looking at our local data. What you can see here is Hamilton. We are doing very similar to Halton, Niagara, Brand, so our adjacent public health units. We are sitting at roughly half the number of cases per 100,000 population than where the Ontario average is, and are roughly at the quarter of where Toronto currently sits, or Ottawa. So that's something to keep in mind. We, again, similar to where we had been in wave 1, we don't have the same epidemiology locally as those areas have that are currently driving the provincial numbers. We have a threshold set up for doing additional asymptomatic testing once we are crossing 20 per 100,000 per week of unlinked or community cases, which is the best reflection of the risk of someone entirely asymptomatic coming in from a community. And we are not there yet. All of this being said, we are looking at this data pretty much daily. We are in ongoing discussions with public health. We get background information from public health. To what extent do we have, when we have an increase of 20 people, is that clusters? Is that 20 with unknown links? And all of this information is being collated to make those decisions. I think I stop here and hand it over. Thank you.
So I guess I'll punt to the next person. Next we're going to hear a little bit about the alternate health facility that is coming up. And I believe Sharon Pearson is going to give that update on this town hall. So Sharon, over to you.
Okay, thanks very much, Aaron, for that introduction. And I'll start off with first, what is an alternate health facility? And first and foremost, an AHF is an extension of our hospital. So it is a legitimate hospital. And it is a facility that can exist on a site existing premises of a hospital, or it can be located somewhere else. And they can be temporary or they can be permanent. And two examples that you may have heard about in the province, one that's a temporary on-site structure would be the structure at the Joseph Branton Hospital, referred to as the tent or the structure, a pandemic response unit. Another example would be the reactivation centers that have been opened over the last few years, primarily in the GTA area, in old hospital premises to support the ALC population. So those are two examples of how these AHFs might come into existence. Primarily, they are used for the lower acuity patients, like the alternate level of care patients, as ours will be, and we'll talk about that in a few minutes. But primarily, they do provide us with additional physical capacity for our hospitals. The alternate health facility, which we are referring to as the satellite health facility for HHS, will open at 150 King Street East, and many may know this to be the Plaza Hotel, or formerly the Plaza Hotel in the Effort Square in downtown Hamilton. The other landmark is it sits just east of the Starbucks downtown, if anybody knows that area. And it has been a hotel for many, many years. Most recently, though, it served for housing for Columbia College and for other community agencies. There is some utilization as a hotel, but that will stop, as will the other uses of the hotel once we occupy. And we are occupying that building, and I'll talk about the details in a minute with St. Joseph's Hospital. Currently, there's a number of renovations underway, so we can convert the physical space of the hotel into a proper healthcare space. We'll go to the next slide. In terms of the rationale of why we are pursuing this at HHS, really it's threefold. We all have heard on these town halls and through the media and through other venues that hospitals must protect 10% of our acute capacity for a potential COVID surge. So for HHS, that's in excess of 100 beds we need to always have available in our acute care sites for that potential use. We also are driving to get up to our pre-COVID volumes for our elective surgical care. And with our historical occupancy pressures that we've had, that can be very difficult for us and concurrently try to protect this 10% capacity. And then lastly, there are expected and there are pressures in our post-acute capacity areas in the community. The long-term care homes with the directives related to COVID have had to reduce their 4-bed rooms, and that's several hundred beds lost for Hamilton. And the homes also, as we would expect, are working very hard to create areas for social distancing for their staff, but also for their residents, and that too is impacting the capacity in the homes. And then lastly, we also don't know what to expect this fall, this winter, with the flu impacts on this particular older, frail population. So there's really 3 primary driving factors for us looking at developing an AHF or the satellite facility. Let's go to the next slide. So the model that we've been working on for the last several months, we've been working on in partnership with HHS. The facility we will open, we will function as 2 separate organizations, each with our own AHF in the same building. There's 5 floors at the hotel, 3 for HHS and 2 for St. Joe's. We are staffing that as we would a hospital, and the model would reflect the patient population for ALC's population. We've had the large group that we've had has had a number of stakeholders participating, everyone from IT to security to those involved in disaster preparedness, so that we're transferring all of those policies and procedures over to the hotel. We've been working to set up the hotel rooms so they look like a hospital. So we'll have hospital beds, overbed tables, etc. Modifying some of the facility, particularly the washroom areas for wheelchair and walker access. We've been developing congregate spaces at the hotel for staff, for lounges and other facilities. We will have the amenities for our patients around Wi-Fi and TV. There's been a group working with Compass to look at our support services related to environmental services and nutrition services, and a lot of work being done to prepare the clinical model and complete the hiring for the facility, along with developing the medical model for the facility as well. I'll go to the next slide. Our plan is that the agreement with the ministry is we have the AHF through to March 31st. We know that could change depending on the circumstances, but that's our planning date. We were really fortunate at HHS to be the recipient of the multi-million-dollar funding announcement last week by the province that will help support the AHF. We have had active recruitment underway for weeks in anticipation of this approval, and we are ready for our first 30 beds and to occupy those beds. And we are pressing very, very hard to meet an October 20th occupancy date with the plaza or with our satellite health facility. There's a number of meetings in progress that have been set up with the clinical teams. We're identifying the appropriate patients to transition and transfer to the health facility. And there'll be much more communication out to the teams as well with respect to the details and how we will operationalize and embed the health facility as one of our sites within AHS, or HHS rather. Very excited. I can't thank all of the individuals that have been participating to put this model together, but it has been a great effort on behalf of a number of individuals. So thank you to that team, and more will come in updates on the AHF. So back to Aaron, I believe.
Thanks a lot for that update, Sharon. Next, I want to call on Bruce Squires, our VP of Women's and Children's Health, to talk a bit about some of the advocacy that we've been undertaking around children's healthcare and access to children's healthcare. For those on the call that are spectator readers, you will have noticed that there was a headline this week. Bruce, can you give us a little bit of an understanding of what's going on and why?
Sure thing. Thanks very much, Aaron. And I am really pleased to be able to talk to folks about child health advocacy. You'll see I'm coming to you virtually from the virtual playground at the Ron Joyce Children's Health Center, which is a beautiful spot and a place of kind of joy and play. But this is not really a joyful or playful topic. I think folks know that, as McMaster Children's Hospital is actually one of the largest and fastest growing children's hospitals. And we have a leading kind of research effort with groups like the Offord Center for Child Studies and CanChild. And so we've really felt traditionally and going forward a responsibility to our broader community to be advocating for the health and well-being of kids and families, not only here in Hamilton, across our region, provincially, nationally, and even internationally. And so, as the pandemic got underway, and throughout the pandemic, we've looked for ways to provide supports to children and families in the broader community. Things like the 33 Caring During COVID videos that our teams produced, the Back to School website that I hope many of you with families did access for advice and tips for managing this different back to school time. And we were involved in the process to create the provincial guidelines for the reopening of schools. And so, while those things I think are hopefully valuable and helpful to supporting kids and families and providers around the region, the reality is that the pandemic itself has actually severely impacted access, again, here and across the province, to healthcare for kids and families. In the first wave, we appropriately, really as governments, focused on the the virus, and on the infection experienced most severely by our seniors, our elderly population, and more vulnerable, primarily adult groups. And then we turned ourselves to a large extent to focusing on recovering economic activity. But unfortunately, what that has meant is that to a large extent, we've ignored child and youth health and the impact on our kids. And the reality is that that impact is severe. Really, while the virus itself certainly infects more severely other populations, kids and youth are severely affected by the virus and by the measures we've taken. Certainly the loss of in-person school really has a long-term impact on children and youth. It affects their cognitive, their mental, their physical, their social, and their emotional and developmental growth. And restrictions that we had to place on access to care meant that we had huge increases in our surgical and procedural wait lists. We had less access to mental health care, and not surprisingly, the time has meant that the need for that care has increased. And what we really see is delayed access to the identification and the treatment of developmental and rehabilitation needs for kids and families. So what that really means for kids and families, or for children and youth, is that often they're missing those key milestones, those key windows for identification and then treatment. And when those milestones or windows are missed, then there can be significant long-term impacts. So I've mentioned that it's been big across the province. Just to share, here at McMaster Children's and here in Hamilton, we have seen, for example, our wait lists for surgical procedures, the number of kids that are waiting beyond clinically accepted times gone up by 133%. Mental health, I talked about mental health. Our referrals to our outpatient service are up 68% in recent months. And wait times for infant assessments and treatments for things like OT and speech language and physiotherapy have gone from 2 and 3 months to a year. So in the context of those really significant challenges to access to healthcare, and therefore the significant risks to the future health of kids, we've helped to launch some campaigns targeted at raising awareness and raising government focus, both nationally and provincially, trying to ensure that kids and families become a priority during the pandemic in terms of management, also recovery and going forward. So some of those activities, they've included some public opinion polls, they've included op-eds, some report releases, advertising, town halls, many more different interactions. And provincially, we've created a child health coalition, so hashtag child health coalition, and that's really focused on the provincial need for improvements to access to care for kids and families. That included a town hall that the Minister of Health attended that you see referenced here, and I encourage you, if you get a chance, to go in and listen. Most compelling in that town hall were the voices of parents speaking to the impact on them and on their kids. Op-eds from both Dr. Peter Rosenbaum in the SPEC and myself in the Toronto Star, a number of media interviews which continue, social media, and for social media, encourage us to look for the hashtag Kids in Crisis. And so, I appreciate the opportunity to highlight this to folks, and really encourage you, if you have an interest, to take a look and to share with your friends and family, and share publicly. So with that, Aaron, I'll pass it back over to you.
Thanks a lot, Bruce, for that update. Good stuff. I have some questions here in the question box, and I'm going to go through those. And as well, I have some that are coming up from our last town hall. Again, just a reminder, if you'd like to raise your hand in the participants function, you can ask a question live, or you can tap something into the Q&A function on your keyboard, and we'll ask it for you. So I guess one question that I'm seeing here that also came up in the questions from the last town hall, maybe Dr. West Stephen, I can ask you to address this one, is, in the context of ramping up, we're hearing about what does that look like in terms of what risks are there associated with ramping up? How will that impact people's care? Can you talk a little bit about how we're approaching that topic and how we're addressing some of those concerns that might be arising as we're increasing what we're doing, but there's still COVID?
Thanks, Aaron. That's a great question. I think I would suggest to our organization that there's a lot of worry on both sides of the coin. On one hand, we are concerned about the rising community cases, but we're also concerned about, you just heard from Bruce, that, kids in crisis. And so we're worried about the non-COVID impact on our patients and their families across all disciplines. And so the planning that's occurred at Hamilton Health Sciences is, I would describe as an accordion that can expand and contract. And so, as we're all aware, there's multiple phases of ramp up, and the teams, the task forces that Rob has alluded to, have put together a very comprehensive plan that allows us to ramp down in a phased way, or continue to ramp up. The triggers for that, of course, will be really around, what is going on, both from a provincial direction, of which we may, as we know, about 6 months ago, were instructed to ramp everything down as much as possible. But also, as Dominic spoke to, is what is the epidemiology in our local community. And so there is a lot of weight put on the scientific evidence and our subject experts, but there's a bit of an art for the organization to walk through about triggering when should we slightly ramp down or continue to ramp up. At the end of the day, we have a lot of patients and families that are waiting for care that has been deferred for 6 or 7 months. And so our ability to continue to provide care is our foremost thought about our backlog, about things that have been deferred. So we continue to look at our PPE, blood products and drugs, etc. And I think we are much better positioned to hopefully have an accordion that can respond to the crisis and where we are in the wave. So thanks for the question. I think to answer it, we are all concerned about both sides of the coin.
For sure. Okay, well, thanks for that response. I also see here a question about the vaccine that may be coming down the pipe. I don't know, maybe Dominic, Dr. Mertz, if you could comment, maybe others might wish to jump in from our clinical leaders about, what is the prospect of HHS being involved in the distribution of such a vaccine? I know that's hypothetical at this point, but what would the logistical elements be with rolling something like that out? Can you comment at a high level as to what that might look like and what the prospective role for a hospital like ours might be?
Yeah, thanks, Aaron. I'm not aware of any discussions that may have happened at the hospital level, but if there have been any that I wasn't involved, please, for the others to weigh in. As you said, Aaron, I think at this point it is a hypothetical question, but one that we should start to consider. But I think that's at this point more at the provincial or national level to decide which population should have priority for the vaccine. Should it be the elderly that have the highest risk? Should it be healthcare workers because of their exposure and the risk of exposing others? And of course, other essential workers? Or should it be because how the vaccine works, maybe those that are driving the epidemic at this point of time, which would be the 20 to 40-year-olds. I think that's the first decision that has to be made. And then depending on who's prioritized, there will be, in my mind, different ways how to administer the vaccine to as many people as quickly as possible. And I keep saying, even if we know in a month or two that one or the other vaccine candidate actually works very effectively, it will still take several months to get started to vaccinate people. And until we have a critical mass of people vaccinated, we will continue to have to live with COVID-19. So it will not change anything from one day to the next.
Thanks for that. Thanks for taking that on. Yeah, a lot to be determined, something that maybe we can revisit as a topic in these town halls as we go. If you did happen to tune into the US presidential debate the other evening, then you'll know that the vaccine is just around the corner, as according to President Trump. Anyways, moving right along, a question here about the inpatient beds that might be in tent-like structures. I know right now there is a satellite tent-like structure at Joe Brant Hospital. I think, Rob, you've had the opportunity to tour that facility. Can you talk a bit about that? Are they heated? What does it look like in there? And you know, how does that fit into our planning?
Yeah, thanks, Aaron. You're right. There is a tent-like structure which is referred to as a pandemic response unit, which has been created or set up at on the campus of Joseph Brant Hospital in Burlington. Joseph Brant is part of a group of hospitals across our LHIN, which has been meeting and developing a COVID model of care on the basis of the whole region. So that's been really great work that's been done. And one of the outcomes of that work was to identify that PRU, Pandemic Response Unit, as a regional resource. In other words, despite the fact that it's located in Burlington on Joseph Brant's hospital site, it is a resource that will be made available across the whole of the region, but not just for, I think, you know, the idea for the PRU is not to use it in a circumstance like that we are in today. It's really if we start to see significant spikes in the number of patients, or if there's a very significant identifiable cohort of patients that gets identified. For example, you know, if we had all of a sudden 50 migrant farm workers living in the same bunkhouse who all got COVID at the same time, I think that would definitely be seen as an appropriate resource to bring into play for a circumstance like that. Or if, you know, if wave 2 ends up being, you know, very significant and all of our resources are stretched, I think the PRU could also be brought into play. It is intended for mild to moderate COVID positive patients. So these will be patients who require acute care, but do not require intensive care for their care. I guess the only other thing I'd say, it's, you know, I have gone for a tour of it. It's an impressive facility, completely heated and cooled. It was recently winterized, so it's good to go for the coming winter months.
Thanks for that. Next question about the alternate health facility. Sharon, perhaps you can comment. A question from Lucy Caruso asking, number one, saying, thanks for the work getting this up and running. The question is, would there be a fee to patients who get transferred to the AHF or SHF?
Thanks, Lucy, for the comment. And the question, the only fee that would apply, if we would call it a fee, is the copayment that applies to the long-term care patients. And that copayment exists now in all of our sites. So there'll be no other new additional fee for any patient moving to the AHF.
Thanks for that. Next question comes from Trevor Johnson. Maybe Michelle Leroux, I can call on you around this question, specifically given the, you know, the concerns about the well-being of children expressed. I think that was, you know, certainly true as we open up schools. and in addition, the service backlog. However, given the risk, I guess, in schools and, you know, increasing exposure in the community, would we consider anything to further expand and encourage people to work from home? I know we've already implemented quite a broad directive in our organization. How are you viewing that right now?
Well, that's a great question, actually. I think we're just turning our minds to that again. You're right. We're waiting to see what the schools are going to do. Where there's a group that was already coming together to look at how we might return people to locations. Of course, with the numbers that we have now, we're turning our mind to, again, supporting people. So nothing, I would say, imminently on the horizon, but definitely a question that's on our mind. So maybe we can move that to our next town hall, Aaron, and I can bring back more details.
Sounds good. Thanks for that answer. Now I got a question here about the HIS recruitment. I'm not sure if Dr. Lum, Barry Lum, is with us today. I don't have all my participants up. You know, like you usually have the Brady Bunch there of everybody that's on the webinar with you. I can't see if he's here, but maybe Michelle, if he's not, you could speak to this about the recruitment. Where are we at with that? And in addition, is there any way for people to follow up?
Oh, great question, Aaron. So there was, I know that people have spoken. If Barry's on the line, he can jump in too. But the amount of interest was, we were so impressed. It was more than we could have ever anticipated. So many people, the majority of the people have been contacted or are beginning to be contacted for things like references, verbal offers. But again, I think we had interest. I can't even remember the number, but over 1,500 people interested. So ask that you kind of bear with us for a little bit. I would say, I would hope by next week, everybody would have heard back on some level, but definitely progressing through, but these things do take time, obviously.
Great, thanks very much for that. I'm just looking here in the chat function. I have a couple of questions too. Is there a plan for long lineups of patients and visitors at screening as we head into the colder months to prevent people from having to wait long periods outside in the elements? Not sure if I can get someone to, not really sure who to call on for that one, but if someone wants to jump up and answer that question, I would think that we would be looking at measures to try and shield people from the elements to the best of our ability.
Aaron, so Sharon might be able to supplement my answer, or even Wes, but I think it's probably reasonable to start off by saying that the province just changed its guidelines as to who is giving us some ability to prioritize the patients who are eligible for testing. So, I mean, we just wrote an op-ed that I think will be published in the Spectator in the relatively near future, really encouraging people to look at the guidelines for when a COVID test is appropriate. And so, you know, in some respects, hopeful that that will help to moderate some of the demand for testing that's going on. I think the other significant occurrence is that we went to an online booking system for people to get an appointment for testing. So again, encouraging people to really take advantage of that online system as opposed to just showing up as a walk-in and hoping to get a test. So I think to the extent that we can get folks onto that online system and booking their tests, it should help to ease those long lineups. And then, of course, the province has promised to open up a number of pharmacies for COVID testing. I think, you know, particularly for those people who are asymptomatic, those will be very appropriate venues for people to go to. So I think the supply of testing should also increase, which will help to moderate those lineups.
Thanks very much for that, Robin. Certainly that we've seen those lineups at our assessment centers, but you know, also in our screening at our sites. I wonder, Kelly Campbell, can you maybe expand on Rob's response as it relates to screening at our sites and what we might be planning as we start to, hey, it's October 1st, the leaves are flying, before you know it, it'll be winter. What will that look like as the colder months start to roll in?
Yeah, so we're just starting that planning now. Thanks, Aaron. So we're looking at a couple different strategies. We want to have a corporate approach, not just a site-based approach. if a site has a large enough lobby that we can queue people inside safely, that's definitely our first preference. It's going to be the best coverage in terms of heat and keeping people out of the elements. So we'll be looking at that. For other sites, we will have to look at some type of outdoor structure. We're engaging a consultant actually to help us look at all of these options, which facilities will need it, which can get along with the underground parking garage at Mumsy as an example. So we're just doing that work now, appreciating that the cold weather is coming and more rainy season. So we're a few weeks away from having something in place, but we're definitely working on it.
And would that include looking at opening up some of the entrances that haven't been accessible at this point?
Not at this point, because as soon as we open up other entrances, it means more screeners. So we're not looking at it at this time, but we are looking at just doing a better job of either pulling people into the building or making sure that they're appropriately protected from the elements.
Got it. Thanks very much. I have a question that's popped up in the chat function, and also a similar question that came through between the last town hall and this one about priority access for screening for families, for the family of people working at Hamilton Health Sciences. So is this something that we might consider for either the children or individual staff members' families? I think, Dominic, maybe you could start us off from an IPAC perspective. Is this something we can operationalize? What are the benefits? What are the challenges?
Yeah, so I assume now it's about testing and not the screening. So as people are aware, we still have long wait times until you get a test. So I just checked this morning, if I wanted to get a test at our local assessment center today, I would have to wait until Monday until I would have the first appointment locally to get testing done. Now that's obviously a major challenge, not only for our staff, for everyone else out there as well. This is certainly a fluid file, and we are working internally as well as with Ontario West and Public Health on a solution which should be regional to the largest extent. And on top of that, just to mention, the lab backlog has increased significantly as well at the provincial level to 80,000 now. So the system is currently out of capacity, I would say. You can be reassured that this is something we've been working on for the last couple of weeks, sort of anticipating first that this is going to happen, and then it did materialize. And we are trying to find a solution that may allow our staff members or the household members of those staff members to get testing as soon as possible, and we will keep communicating how that solution may look like. But again, given that it's a bottleneck now at the provincial level, it needs a thoughtful solution.
So on the one hand, we can get more people in, but the test might not be expedited given the lab capacity.
I mean, we have some abilities to expedite tests, but only to a certain amount, right? And then the question is it the right thing to prioritize testing in the lab for a child with sniffles over a patient who's waiting in an ED? And these are all the other conversations that have to happen at the same time as discussing whether we will have an option that people can jump the line to get the testing done.
Great. I also see, while I have you up here, another question just popped in about the effectiveness or accuracy of the Health Canada approved 90-minute test machine versus the traditional lab-based test. I'm unfamiliar with this, but maybe Dominic, you know what this is.
Yeah, I will be learning more about it as well. It's not as sensitive, so not as reliable in picking up someone who's positive, but probably, or it seems like it's sensitive enough. Will it be the solution to all our problems? The answer is unfortunately no. Also, it gives you the results back quicker. It's one test after the other, so there's also limited capacity there. There are several groups across the province and also nationally working on finding solutions how to increase capacity much more significantly than with the solutions that now have Health Canada approval. So more work to happen, and there's discussion at the provincial level how to use those, let's call them novel technologies or novel tests, and how to add them to our current NPS PCR test that we have been using since March.
Awesome, thanks. Conscious of time, we're at about 20 minutes past 12. We want to wrap at 12:30, and I want to leave some time for our celebrations. Before we go there, just want to remind everyone, if you had a question, you didn't get to raise it, maybe you did raise a question, but you want more info, or maybe you think of a question later, you can always send those to hhsnews@hhsc.ca, and we'll be sure to get you an answer. Additionally, you could propose something that you'd like to discuss live at our next town hall. That's always really helpful for formulating these agendas. So send that through. Your feedback's welcome in addition. So why don't I call on on Rob again to lead us through our celebrations. Same format applies. You can write it in there and we'll read it out, or you can raise your hand and let her rip live.
Yeah, thanks very much, Aaron. And Aaron and I have been sort of co-hosting this section of the agenda, but first of all, thanks everybody for another engaging question and answer session. Lots of good questions. In keeping with our town hall tradition, we'll close with celebrations, as Aaron was saying. So just encourage folks to give a shout out to a colleague or a team who you think is, you know, really going above and beyond and deserves some recognition. You could either speak up using the chat, or you could raise a hand. I can tell you would make Aaron's day if
I'm already chomping at the bit. I see Leslie Gauthier here with her hand raised. So Leslie, why don't you go ahead and celebrate.
Just in the theme of a lot of the conversation and what's in the media, I really wanted to give a very warm thanks to the staff working in the labs. They have been working full out, maximizing all of the capacity in the lab and bringing up some new equipment and just really trying to do an awesome job to get the test process. So big thank you to all of them.
Thanks, Les. Kelly Campbell has one.
Yeah, I just want to acknowledge our very active group of site volunteers that are helping with our United Way campaign this year. We had a story on the Hub yesterday. Our campaign is still very active. We've delayed our launch to mid-October this year, but just to acknowledge Lisa Webster and Donna LaForce, who are co-chairs for the committee, and the many site participants that are helping us along with the United Way. We're looking forward to a great campaign.
I see here in the chat function from Kelly Turner, happy International Day of Older Persons. Congratulations to my coworkers in the health and geriatrics teams for all the great work they do supporting seniors every day. Good stuff. Calling out for celebrations, calling them out. Who else has got one?
Yeah, I think it's I know we heard from Sharon Pearson and her team today. It is an amazing amount of work that's been done to get that alternate health facility, you know, created, the concept created, all the negotiations, all the work that went into organizing that. It's quite an amazing feat. So I'll give a big shout out to that whole team for doing amazing work.
Good stuff. I see here a recognition of Happy Occupational Therapy Month. So another recognition month. Reminders to everyone that as recognition days, weeks, and months arise, you can also email into if you have something you'd like to include, a piece of writing to get pushed out through our Hub or Hub app. That'd be a lovely contribution to make for your colleagues. So you're always welcome to do that and follow the process that's outlined there for that to occur. All right.
Okay, Aaron, maybe you could help bring us home.
One last one here from Daniela Bianco, acknowledgement of October being Research Awareness Month 2 at HHS. Say that a few times fast. So thanks, Daniela, for that one. And I know there was some great stories circulating on Twitter today about that out of HHS. So good stuff. Also see here from Leslie Gillies, thank you to the SBH staff and physician volunteer green team who planted trees Saturday, September 26th in the SPH courtyard for the second annual event where the old South Wing was situated. So good stuff. And Healthy Workplace Month. Keep an eye on the hub for more details from Michelle Cassidy. So thanks for that. So I think we'll wrap there. Thank you for the celebrations. Thanks to all of our panelists. Until next time, stay safe, and we look forward to hearing from you on hhsnews.ca at hhsc.ca in the meantime. Okay.
Thanks, Aaron. Thanks all. Have a great day.